الخير. النهارده هنتكلم على الهيستروسكوب او المنظار الرحمي في مجال امراض النساء وتاخر الانجاب واطفال الانابيب. هنتكلم على طريقه عمل المنظار التشخيصي وتطبيقاته واهميته. هنتكلم على كمان اهميه الفحص الطبي الكلينيكي وبالموجات الصوتيه خصوصا الثلاثيه الابعاد، واهميه معرفه كل شيء عن المريض بكل التفاصيل قبل ما نعمل المنظار الرحمي. المنظار الرحمي ممكن يتعمل تحت تخدير كامل او تحت مخدر موضعي، وليه اهميته وتطبيقاته الكتيره في حاله حدوث اضطراب في الدوره الشهريه، او في حاله تاخر الانجاب او السقط المتكرر، وكمان في حالات الحقن المجهري لما بنحس انه في حاجه ممكن تتعمل تاثر على النتيجه بالايجاب ان شاء الله. هنتعرض في الحلقه دي على طريقه عمل الهيستروسكوب، وهندي امثله كتير على الحاجات اللي بنشوفها وكمان امكانيه علاجها، وزي ما هنشوف مع بعض دلوقتي.
We're going to talk today about the hysteroscopy, which is the examination of the uterus. Before talking about the anatomy of the uterus, we have to know that the uterus is 7 to 8 centimeter in length and 4 to 5 centimeter in width, with a thickness of 2 to 3 millimeter. The uterus weighs 50 to 80 grams, and it's divided into three portions: cervix, the body, and the fundus and the isthmus, which is a junction between the cervix and the cavity. Okay. It's very important before the hysteroscopy to consider the very important items. Patient preparation is very, very important, and being aware of the patient history is of paramount importance. We have to review the indication of the hysteroscopy and to make sure it's needed, and to identify the risk factors of the patient, and to make sure that you are aware of the previous surgeries of the patient or any risk factors like high BMI or previous scars in the uterus, which is very, very important. Also, it's very important to inform the patient and to take an informed consent, and it's very important to explain the benefit of the procedure in detail, and also to make sure that you explain the complication of the hysteroscopy, mainly to make sure that you explain the risk of perforation and the risk of pain and bleeding. Also, you have to be aware of the position of the patient before the hysteroscopy. She has to be in the lithotomy position, and this is very important. Examining the patient under anesthesia is very important as well, and you have to make sure of the position of the uterus, whether it's anteverted or retroverted, and also it's an opportunity to comment on the descent of the cervix and any prolapse, which can help in further management. The hysteroscopy, it's must to have a pelvic ultrasound scan, and now with the technology of the three-dimensional ultrasound, with or without the saline sonography, you can diagnose lots of pathologies. Like for this case, for example, this is a three-dimensional ultrasound and with saline sonography, and you can see easily the presence of uterine polyps, endometrial polyps. For the hysteroscopy, you have to also be aware of the component of the hysteroscopy. You have to have the endoscope. You have to have the sheaths, which allows the insertion of the endoscope in the cervical canal. Also, you have to have a cold light source, and also a distending media, which we'll explain in details later on. After you have assembled the hysteroscope properly and connected the light source, you have to identify the cervix as shown, and under aseptic technique you insert gently the hysteroscope, and as you can see here, this is the insertion of the hysteroscope through the cervical canal, and on top this is the picture how it looks like the hysteroscope, and once it passes through the isthmus, you can see easily the uterine cavity. Without changing or moving the hysteroscope, with a very gentle maneuver of the camera, you can see both ostia on both sides, and this you have to comment on the presence of any pathologies or if it's a normal cavity. So this is the insertion of the hysteroscope, and this is an illustration how it looks like with the standing media when you look inside and the media distend in the cavity and you can see the cavity inside. And to comment on the hysteroscopy finding, some are normal findings, like in this case, this is a lady who had a postmenopausal bleeding, and you can see the atrophic endometrium with no pathologies at all, and both ostia were seen clearly in the panoramic view, as you can see there. So it's very important to have a quick look and also to have a systemic review of the whole cavity. Also, you can find myomas, which, like in this case, you have a look inside once you are in the cavity, and you can find a large submucous fibroid, like in this case. You can see the peripheral vascularity, which is very characteristic of the myomas. The good or the important part of the hysteroscopy, it can also allow therapeutic treatment. So you can add the resectoscope and remove the myoma. For this case also, there's another submucous fibroid in this postmenopausal patient. Polyps are very common in hysteroscopy, and as you can see here, this is a polyp with a lady with menstrual disorders, and the polyp is seen and it's pedunculated, and you can easily remove it. This is another example of a polyp which is protruding to the lower part of the cavity, and as you can see here on the top, this is a fundus and both ostia, and the polyp can also be easily removed by polypectomy or resectoscope. This is another view of a polyp in the cavity, which is again in the lower part, and you can see easily remove it by resectoscope or polypectomy. Hyperplasia can also be found, especially for the ladies you suspect hyperplasia on ultrasound scan, mainly with perimenopausal bleeding or postmenopausal bleeding, and in this case you can see hyperplasia of the endometrium, and a biopsy is needed to decide further management and whether there's atypia or not. You can see here the hyperplastic endometrium in this postmenopausal patient. And it's also an important practice to have a look on the other part systematically on the uterus, as you can see. Carcinoma is one of the very important pathologies which we always suspect in postmenopausal patients, especially if the endometrial thickness is more than 5 millimeters. And in this case, hysteroscopy was done for a lady with postmenopausal bleeding, and a malignancy was suspected. As you can see, the endometrium looks abnormal with high suspicion of malignancy, with neovascularization and abnormal looking endometrium. As you can see here, this is the abnormal vasculature. This is another example of endometrial cancer, also diagnosed after high suspicion on ultrasound and confirmed by biopsy. Septum is another finding for patients who trying to conceive with subfertility, and it's very important to, if you suspect the septum, to undergo hysteroscopy with the plan to resect or to remove the septum before IVF, because this can affect the treatment. And for this patient, she had 2 previous miscarriages, and septum was suspected on ultrasound scan, and as you can see, the septum is very, very clearly seen, and as you can see, there seems like 2 cavities, but it's a septum, long one. This is another subseptate uterus, which was a lady with previous history of recurrent miscarriage, and this was treated successfully. Adhesions is also another important finding of hysteroscopy, especially for ladies with a history of hypomenorrhea or thin endometrium on ultrasound scan, and also history of previous DC. Sorry, ممكن أعيد بس الحتة دي. Adhesions is also an important finding of the uterus, and you always have to comment whether there's adhesions or not, especially if she had a subfertility or she had a history of hypomenorrhea or dilatation in curettage. Lost IUDs is also one of the indication to do a hysteroscopy to try to remove it. As you can see here, there's a misplaced and missed IUD, which was retrieved successfully.
زي ما شفنا في عملية المنظار الرحمي الأمثلة الكتيرة قوي اللي تعرضنا لها، وكلها حاجات مهمة جدا في التشخيص والعلاج، وطبعا ممكن تأثر جدا في الصحة العامة ونتائج أي علاج بعدين. زي ما قلنا ممكن طبعا تفرق جدا في نجاح أطفال الأنابيب والحقن المجهري، وممكن طبعا يبقى فيها طريقة شفاء باستخدام المنظار الجراحي، ودي حاجة ممكن تشفي أو تحسن كتير جدا من حالات الاضطراب الدورة الشهرية.